This video presentation describes the basic events of upper and lower limb development and provides examples of anomalies resulting from disrupted development. The limbs grow as a result of tremendously dynamic interactions between the ectodermal and mesodermal elements of the limb bud. What causes a limb to grow? How do the fingers and toes form? How does a digital ray in a developing hand know to become a thumb instead of an index finger? Normal development involves a variety of genes, time gene expression, transcription factors, signaling molecules, and feedback loops that regulate limb patterning, outgrowth, cell differentiation, and programmed cell death. Significant advances in recent years have been made experimentally using chick and mouse models to understand the key players exerting influence during limb growth and differentiation, as well as for limb defects. Gene mutations with loss of downstream expression alter this developmental dynamic and produce limb abnormalities. While we will not focus on the many molecular details involved in this presentation, you are encouraged to explore these on your own if you are interested. In addition, much of what you will learn in this presentation regarding groupings of limb musculature, their innervation, and dermatomes will be reinforced and expanded upon in the dissection lab. This list of learning objectives will guide your learning of the content of this presentation. I wish to begin by making several key general points about limb development, which will be expanded upon as we progress. Limb buds appear along the ventrolateral body wall in particular locations. The upper limb buds appear opposite somites C5 to C8 and T1 at about day 24. The lower limb buds appear about a day or two later, by day 26, opposite somites L2 to L5 and S1 to S3. Limb buds consist of an outer covering of ectoderm and an inner core of mesenchymal cells derived from two different sources, lateral plate mesoderm and somatic mesoderm. Lateral plate mesoderm gives rise to the bones, tendons, ligaments, and dermis of the limb. The muscles of the limb are derived from the myotomal cells or precursors of muscle fibers that migrate into the limb from adjacent somites. There is a critical period of limb induction between days 24 to 36 of gestation, when fetal exposure to teratogens or to environmental toxins can lead to limb defects. The classic historical example of this was the use of thalidomide by pregnant women in the 1950s and early 1960s to treat morning sickness. We will discuss this at the end of this presentation. Limb development occurs in a 5-week interval between weeks 4 and 8 of gestation. How do limbs grow? Limb growth and differentiation occur along 3 axes. This external view of an early embryo shows an emerging upper limb bud with these 3 axes labeled. Each dimension is controlled by a separate process with unique genes and growth factors involved. The proximal distal axis extends from the shoulder or the hip to the hand or the foot. It consists of the 3 bony segments of the limbs: humerus femur, radius and ulna, tibia and fibula, carpals, metacarpals, tarsals, metatarsals, and phalanges. The anterior-posterior axis, also known as the cranial-caudal axis, extends along the superior and inferior borders of the limb buds. It regulates the formation of the thumb and big toe near the anterior border and the little finger and little toe at the posterior border. The third axis, the dorsal ventral axis. The dorsal component of this axis represents the knuckle side of the hand or top of the foot, while the ventral component is represented by the palm of the hand and sole of the foot. Initiation of limb outgrowth occurs by growth factors expressed in the lateral plate mesoderm prior to limb bud formation. Thereafter, elongation is regulated by the apical ectodermal ridge, or AER, a thickening of ectoderm along the distal edge of each limb bud at the interface of the dorsal and ventral axis. unique growth factors expressed by the AER stimulate proliferation and outgrowth in the underlying mesenchyme. Bony structures form in a proximal distal direction. That is, the humerus and femur are laid down first in the upper and lower limbs, followed by the bones of the forearm and leg, and so on. The mesenchyme closest to the AER proliferates rapidly and is undifferentiated. Cells farther from the influence of the AER begin to differentiate into the tissues, cartilage, bone, joints of each limb segment. The next two slides show how the fingers and toes form. As the limb buds elongate, their distal ends broaden and flatten into hand plates and foot plates. By the end of the 6th week, mesenchymal tissue in the hand plates condense to form digital rays. These condensations outline the patterns of the digits. Similar events occur during the 7th week in the foot plates. At the tip of each digital ray, a part of the AER induces development of the mesenchyme into primordia of the phalanges in the digits. As viewed here, the intervals between the digital rays are occupied by loose mesenchyme. Soon, these intervening regions break down via programmed cell death or apoptosis, forming notches between the digital rays. There is temporary webbing of the fingers and toes until tissue breakdown has sufficiently progressed to free the digits. This removal does not occur, for example, in the duck foot, which is specialized for swimming. By the end of the 8th week, all segments of the upper and lower limbs have developed and are distinct. Thereafter, the limb elements just increase in size. As it turns out, the most common limb defects are those that affect the digits of the hands and feet. Here we see examples of defects in the hands. Syndactyly refers to fused digits. It is the most common type of limb defect. It occurs when the interdigital tissue fails to break down as a result of failure of apoptosis, resulting in fusion of digits. This fusion may affect the skin only, skin and soft tissues, or skin, soft tissues, and bone. This condition is more common in the foot than in the hand. From a functional standpoint, it is less important in toes, but disabling in fingers, which require surgical separation. Polydactyly refers to supernumerary or extra fingers or toes. These occur when an extra digital ray is formed. Most commonly, the extra digit is on the ulnar side of the hand, the side of the little finger. The extra finger is usually rudimentary. Oligodactyly refers to fewer than normal number of digits. These occur when fewer than the normal number of digital rays form. In the X-ray, the index finger is missing. Having generally described the development of the limbs, here I want to add some additional comments about the stages of prenatal and postnatal bone formation. Bones of the limbs develop via endochondral ossification. You will learn further details of these events in histology, but for now, these are sufficient. The principal point of this information relates to the radiographic appearance of the long bones at birth and during childhood, which make them different from their appearance in the adult. From the illustration below, as the limbs elongate, mesenchymal models of the bones are first formed by cellular aggregations or condensations of lateral plate mesoderm in week 5. During week 6, these condensations subsequently chondrify to form a hyaline cartilage model of the future bones. In weeks 7 to 9, centers of bone formation, also called primary ossification centers, develop within the shaft or diaphysis of the bone. From weeks 9 to birth, the primary centers of ossification enlarge, but the ends or the epiphyses remain largely cartilaginous. Radiologically shown on the lower right, the ends of long bones appear radiolucent, that is, they are more dark, indicating absent mineralization. Diaphyses, on the other hand, appear radiodense, or more white, indicating the presence of bone mineral content. During childhood to adolescence, secondary centers of ossification form in the ends of bones. The epiphyseal growth plate temporarily separates the primary and secondary centers to permit elongation of the bone. Radiologically, at this older age, the ends of long bones appear radiodense, as do the diaphyses. The growth plates, because they are cartilage, persist as radiolucent lines, which should not be misinterpreted as a bone fracture. Now we move on to discuss another major component of limb bud development, and that is the formation of the limb musculature. This involves the mesoderm in somites that are destined to form muscle called the myotome. Myotomal tissue, representing precursors of muscle cells of somites, divide into epimeres and hypomeres as seen in both illustrations. The epimeres migrate dorsally around the developing vertebral column and give rise to epaxial muscles. Examples include the erector spinae and the deep back muscles. These will be innervated by dorsal primary rami of spinal nerves. Hypomeres migrate ventrolaterally into the body wall and limbs and give rise to hypaxial muscles. Examples would include intercostal and abdominal wall musculature and muscles of the limbs. These will be innervated by ventral primary rami of spinal nerves. As mentioned at the outset of this presentation, the upper limb buds appear opposite somites C5 to C8 and T1, and the lower limb buds opposite somites L2 to L5 and S1 to S3. During week 5, myotomal cells of hypaxial origin migrate from these respective somite levels into their limb buds. Myotomal cells organize next to the developing skeletal elements and form ventral and dorsal muscle masses, which later differentiate into anatomically recognizable muscles of the limbs. In general, dorsal muscle masses give rise to the extensor and supinator muscles of the upper limb, and extensor and abductor muscles of the lower limb. In general, ventral muscle masses give rise to the flexor and pronator muscles of the upper limb, and flexor and adductor muscles of the lower limb. Limb muscles are innervated by ventral rami of spinal nerves. Because of their somatic origin, it should not be surprising to learn that the nerve supply to upper limb muscles is derived from the brachial plexus, consisting of C5 to C8 and T1 nerve fibers, and the lumbosacral plexus consisting of L2 to L5 and S1 to S3 nerve fibers for the lower limb. These nerve plexuses form at the bases of the limb buds. Motor axons destined to innervate dorsal mass muscles segregate out of each plexus as posterior division fibers, which subsequently combine to form definitive peripheral nerves. Motor axons destined to innervate ventral mass muscles segregate out of each plexus as anterior division fibers, which subsequently combine to form definitive peripheral nerves. Migration of axons from the limb base to their specific muscle targets is an intricate feat of pathfinding. Local factors likely regulate final migration of specific axons to specific muscles in the limb bud. This slide shows the details concerning the formation of the brachial plexus supplying muscles of the upper limb. The brachial plexus consists of roots, trunks, divisions, cords, and terminal branches. You will learn these as you study the gross anatomy of the upper limb. To tie this in with the previous slide, note the blue-colored portion and green-colored portion of the plexus in the illustration. These represent respectively dorsal division fibers and anterior division fibers that segregated out early in development to supply respectively dorsal and ventral mass muscles. Dorsal mass muscles will develop into the extensor and supinator muscles of the upper limb, which are innervated by the radial nerve. Ventral mass muscles will develop into the flexor and pronator muscles, which are innervated by the muscocutaneous, median, and ulnar nerves. Again, you will learn the specific details of these in the dissection lab. For now, I just want to emphasize how muscle compartments develop and are innervated. Knowing this helps with understanding the gross anatomy. Lower limb muscles are supplied by branches of the lumbosacral plexus. Historically, anatomists have not emphasized student learning of the details of the lumbosacral plexus formation as compared to formation of the brachial plexus. Again, I point your attention to the anterior and posterior division fibers, colored green and yellow respectively, that segregated out developmentally and variously recombined to form definitive nerves to ventral and dorsal mass muscles, respectively. Dorsal mass muscles develop into extensor and abductor muscles of the lower limb and are innervated by femoral, common fibular, and superior gluteal nerves. Ventral mass muscles develop into the flexor and adductor muscles and are innervated by the obturator and tibial nerves. Again, you will learn further details in the dissection lab, which reinforces this embryology. Spinal nerves not only play an important role in differentiation and motor innervation of the limb musculature, they also provide sensory innervation for the dermatomes, another component of somites. Sensory axons enter the limb buds after the motor axons and use the motor axons for guidance to sensory end organ receptors in muscle, tendons, and dermis. Recall that a dermatome is an area of skin supplied by a single spinal nerve. Dermatomes present in a segmental fashion early in development, and this is preserved most clearly in the trunk region of the body, seen in the illustration immediately to the right. Dermatome arrangement in the limbs becomes somewhat more complicated because the limbs rotate during development. The following detailed description should help you make sense of these dermatome patterns. The early limb buds emerge from the body and are oriented in a coronal plane. The thumb side of the hand projects cranially in the upper limb bud, and the big toe side of the foot projects cranially in the lower limb bud, seen in the illustration on the left. Sequential segmental dermatomes can be identified from proximal to distal along the cranial border of the limbs that continue from distal to proximal on the caudal border of the limbs. During the 6th week, both limbs move horizontally to become oriented in a sagittal plane. During weeks 6 to 8, the limbs rotate 90 degrees around their long axes, but in opposite directions. This is seen in the illustration on the left. The upper limbs rotate laterally 90 degrees so that the thumb comes to lie on the lateral side and the elbow points posteriorly. In the process, the extensor muscle compartment comes to lie on the posterior side of the limb and the flexor muscle compartment on the anterior side of the limb. This is the arrangement you'll see and study in the dissection lab. This rotation causes the originally straight segmental arrangement of sensory innervation of the skin to become slightly modified in the adult, as seen in the bottom middle illustration. The lower limbs rotate medially 90 degrees so that the big toe comes to lie on the medial side and the knee points anteriorly. In the process, the extensor muscle compartment comes to lie on the anterior side of the limb and the flexor muscle compartment on the posterior side of the limb. This rotation also causes the originally straight segmental arrangement of sensory innervation of the skin to become slightly modified, as seen in the bottom right illustration. It is now easier to understand why the dermatomes innervated by spinal nerves of the brachial plexus are arranged consecutively down the lateral side and up the medial side of the upper limb, and dermatomes innervated by spinal nerves of the lumbosacral plexus are arranged down the medial side and up the lateral side and back of the lower limb. The last 2 slides describe some additional developmental defects of the limbs. Drugs and environmental teratogens that influence general cell metabolism or cell proliferation are likely to interfere with limb development if the fetus is exposed during the critical period of limb morphogenesis. Agents known to affect limb development include anticonvulsant and anticoagulation medications, alcohol, cocaine, and thalidomide. The latter has profound, devastating effects on limb formation. Thalidomide was first marketed and widely used in Europe and Australia in the late 1950s as a sedative, and was also used to treat morning sickness in pregnant women. Within a few years, some 10,000 children were born with missing, called amelia, or partially absent limbs, called meromelia. This led to a ban of thalidomide in most countries in 1962, and to the development in the United States and international regulatory agencies of systematic toxicology testing protocols previously lacking. Since that time, such limb defects have rarely been observed. There has been a recent resurgence in the use of thalidomide in the treatment of leprosy, multiple myeloma, and advanced HIV infections. However, it is absolutely contraindicated in women of childbearing age. To much excitement and fanfare in 2018, the Seattle Seahawks signed linebacker Shaquem Griffin to join his brother on the roster of this NFL team. What makes this story so unique, Shaquem is missing his left hand, but defying the odds by being able to play at this level of competition. Griffin had his hand amputated at age 4 because it was so tender and sensitive to the touch. The frequent pain was nearly unbearable as an active 4-year-old. Griffin suffered from amniotic band syndrome, a rare congenital condition when the fetus becomes entangled in string-like fibrous bands of amniotic membrane. The amniotic sac consists of 2 layers, an outer membrane called the chorion that attaches to the uterine wall, and the amnion that faces toward the fetus. For unknown reasons, this latter membrane may rupture or tear, causing bands of membrane to float in the amniotic fluid and entangle parts of the fetus. In Griffin's case, strands wrapped tightly around his left wrist, preventing his hand from developing normally. Despite missing his hand, he overcame all obstacles growing up to realize his dream to play in the NFL. This ends our presentation on the development of the limbs. As mentioned earlier, an understanding of how muscle masses are first grouped and innervated and repositioned as the limbs rotate will aid learning some of the gross anatomical details of the limbs. I wish you well in your studies.